Coronary circulation. Some major diseases also we are going to learn in this video. About 1/3 of all deaths in industrialized countries of the Western world result from coronary artery disease. However, this has become an increasing problem in developing countries as lifespans increase and lifestyle behaviors change. For this reason, understanding normal and pathological physiology of the coronary circulation is one of the most important subjects in medicine. Physiological anatomy of the coronary blood supply. Main coronary arteries lie on the surface of the heart, and smaller arteries then penetrate from the surface into the cardiac muscle mass. It is almost entirely through these arteries that the heart receives its nutritious blood supply. Only the inner 1 to 10 mm of the endocardial surface can obtain significant nutrition directly from the blood inside the cardiac chambers. So, this source of muscle nutrition is minuscule. So, a left coronary artery supplies mainly the anterior and left lateral portions of the left ventricle, whereas the right coronary artery supplies most of the right ventricle as well as the posterior part of the left ventricle is 80 to 90% of people. So most of the coronary venous blood flow from left ventricular muscle returns to the right atrium of the heart by way of the coronary sinus, which is about 75% of the total coronary blood flow. On the other hand, most of the coronary venous flow from the right ventricular muscle returns to the small anterior cardiac vein that flow directly to the right atrium, not by way of a coronary sinus. A very small amount of coronary venous blood also flows back into the heart through very minute Thebesian veins. Thebesian. Thebesian veins, which empty directly into all chambers of the heart. The normal coronary blood flow averages 5% of cardiac output. The normal coronary blood flow in the resting human being averages 70 ml per minute per 100 gram of heart weight, or about 225 ml per minute, which is about 2 to 4% of the total cardiac output. During strenuous exercise, the heart in the young adult increases its cardiac output 4-fold to 7-fold, and it pumps this blood against a higher than normal arterial pressure. Consequently, the work output of the heart under severe conditions may increase 6-fold to 9-fold. At the same time, the coronary blood flow increased 3-fold to 4-fold to supply the extra nutrients needed by the heart. So, basic changes in coronary blood flow during systole and diastole, effect of cardiac muscle compression. Changes in blood flow through the nutrient capillaries of the left ventricular coronary system in multiliters per minute in the human heart during systole and diastole as extrapolated from studies in experimental animals. So note from this diagram that the coronary capillary blood flow in the left ventricle muscle falls to low value during systole. The reason for this phenomenon is a strong compression of the intramuscular blood vessels of the left ventricular muscle during systole contraction. During diastole, the cardiac muscle relaxes and no longer obstructs blood flow through the left ventricular muscle capillaries. So blood flows rapidly during all of diastole. Blood flow through the coronary capillaries of the right ventricle also undergoes phasic changes during the cardiac muscle, but because the forces of contraction of the right ventricular muscle is far less than that of the left ventricular muscle, the inverse phasing changes are one partial in contrast to those in the left ventricular muscle. So epicardial versus subendocardial coronary blood flow, effect of intramyocardial pressure. Special arrangement of coronary vessels at different depths in the heart muscle, showing the outer surface epicardial coronary arteries. Epicardial coronary arteries that supply most of the muscle. Then smaller intramuscular arteries derived from the epicardial arteries penetrate the muscle, supplying the needed nutrients. Lying immediately beneath the endocardium is a plexus of subendocardial arteries. Which one? Subendocardial arteries. During systole, blood flow through the subendocardial plexus of the left ventricle, where the intramuscular coronary vessels are compressed greatly by ventricular muscle contraction, tends to be reduced. However, the extra vessels of the subendocardial plexus normally compensate for this reduction. Later in the chapter, we explain how this particular difference between Blood flow in the epicardial and subendocardial arteries plays an important role in certain types of coronary ischemia. Salient features of the coronary circulation: 4 to 5% of cardiac output, that is 225 ml per minute, is received. Distribution of blood flow in right and left coronary arteries varies. Some individuals are left coronary artery dominant, others right coronary artery dominant. Extraction of oxygen from coronary arteries is at rest is high. Extraction of oxygen from coronary arteries at rest is high. Coronary blood flow is closely coupled to cardiac metabolism. Coronary circulation shows autoregulation of blood flow. Coronary blood flow is phasic, more during diastole and minimal during systole. This phasic nature is more pronounced in the left ventricle. Coronary blood vessels have collaterals. Control of coronary blood flow. Local muscle metabolism is the primary controller of coronary flow. Blood flow through the coronary system is regulated mostly by local antidiular vasodilation in response to the nutritional needs of the cardiac muscle. That is, whenever the rigor of cardiac contraction is increased, the rate of coronary blood flow also increases. This local regulation of coronary blood flow is similar to that occurring in many other tissues of the body, especially in the skeletal muscles. Oxygen demand as a major factor in local coronary blood flow regulation. Blood flow in the coronary arteries usually is regulated almost exactly in proportion to the need of the cardiac musculature for oxygen. Normally, about 70% of the oxygen in the coronary arterial blood is removed as the blood flows to the heart muscle. Because not much oxygen is left, little additional oxygen can be supplied to the heart musculature unless the coronary blood flow increases. Fortunately, the coronary blood flow increases almost in direct proportion to any additional metabolic consumption of oxygen by the heart. The exact means of by which increased oxygen consumption causes coronary dilation has not been determined. A substance with greater vasodilator propensity is adenosine. In the presence of very low concentration of oxygen in the muscle cell, a large proportion of the cell's adenosine triphosphate degrades to adenosine monophosphate. A small portion of the substance are then further degraded and released adenosine into the tissue fluids of the heart muscle, with the resultant increase in local coronary blood flow. After the adenosine causes vasodilation, much of it is reabsorbed into the cardiac cells to be reused by the production of ATP. After vasodilation, include adenosine phosphate compounds, potassium ions, hydrogen ions, carbon dioxide, prostaglandins, and nitric oxide. The mechanism of coronary vasodilation during increase in cardiac activity are not fully explained by adenosine. Pharmacological agents that block or partially block the vasodilator effects of adenosine do not present coronary vasodilation caused by the increased heart muscle activity. Nerve control of coronary blood flow. Stimulation of the autonomic nerves to the heart can affect coronary blood flow both directly and indirectly. The direct effects result from action of the nerve transmitter substance acetylcholine from the vagus nerves and norepinephrine from the sympathetic nerves on the coronary vessels. The indirect effects result from secondary changes in coronary blood flow caused by increased or decreased activity of the heart. The indirect causes, which are mostly opposite to the direct effects, play a far more important role in normal control of coronary blood flow. The sympathetic stimulation, which release norepinephrine from the sympathetic nerves and norepinephrine and epinephrine from the adrenal medulla, increase both heart rate and heart contractility and increase the rate of metabolism of the heart. In turn, the increased metabolism of the heart sets off local blood flow regulatory mechanisms for dilating the coronary vessels, and the blood flow increase approximately in proportion to the metabolic needs of the heart muscle. In contrast, vagal stimulation, with its release of acetylcholine, slows the heart and has a slight depressive effect on heart contractility. The effects decrease cardiac oxygen consumption and therefore indirectly constrict the coronary arteries. The indirect effects of nerve stimuli on the coronary vasculature. Next topic. direct effects of nerve stimulation on the coronary vasculature. The distribution of parasympathetic vagal nerve fibers to the ventricular coronary system is not very great. However, the acetylcholine released by parasympathetic stimulation has a direct effect to dilate coronary arteries. More extensive sympathetic innervation of the coronary vessels occur. Sympathetic transmitter substance, norepinephrine and epinephrine, can have either vascular constrictor or vascular dilator effects depending on the presence or absence of constrictor or dilator receptors on the blood vessel walls. The constrictor receptors are called alpha receptors and the dilator receptors are called beta receptors. Alpha receptors and beta receptors. Both alpha and beta receptors exist in the coronary vessels. In general, the epicardial coronary vessel have a preponderance of alpha receptors, where the intramuscular arteries may have a preponderance of beta receptors. Therefore, sympathetic stimulation can at least theoretically cause slight overall coronary constriction or dilation, but usually constriction. In some people, the alpha vasoconstrictor effect seems to be disproportionately severe, and these people can have vasospasmic myocardial ischemia during periods of excess sympathetic drive, often within resultant anginal pain. So, metabolic factors, especially myocardial oxygen consumption, are the major controllers of myocardial blood flow. Whenever the direct effects of nerve stimulation reduce the coronary blood flow, the metabolic control of coronary flow usually overrides the direct coronary nervous effects within seconds. Special features of cardiac muscle metabolism. The basic principles of cellular metabolism apply to cardiac muscle are the same for the other tissues, but some qualitative differences exist. More importantly, under resting conditions, Most importantly, under resting conditions, cardiac muscle normally consumes fatty acids instead of carbohydrates to supply most of its energy derived from fatty acids. However, it is also true of other tissues. Under aerobic or ischemic conditions, cardiac metabolism must call an anaerobic glycolysis mechanism for energy. However, glycolysis consumes large quantities of blood glucose and at the same time forms large amount of lactic acid in the cardiac tissue, which is probably one of the causes of cardiac pain in cardiac ischemia conditions. As is true in other tissues, more than 95% of the metabolic energy liberated from foods is used to form ATP in the mitochondria. This ATP is in turn acting as a conveyor of energy for cardiac muscle contraction and other cellular functions. In some severe coronary ischemia, the ATP degrades first to adenosine diphosphate and then to adenosine monophosphate and adenosine. Because of the cardiac muscle cell membrane is slightly permeable to adenosine, much of this agent can diffuse from the muscle cells into the circulating blood. The released adenosine is believed to be one of the substances that cause a dilation of the coronary arteries during coronary hypoxia. Adenosine. However, the loss of adenosine also has a serious cellular consequences. Within a little of 30 minutes of severe coronary ischemia, as occurs in the myocardial infarct, about one half of the adenine base can be lost from the affected cardiac muscle cells. Furthermore, this loss can be replaced by new synthesis of adenine at a rate of about 2% per hour. However, once a serious bout of coronary ischemia has persisted for 30 or more minutes, relief of the ischemia may be too late to prevent injury and death of the cardiac cells. This occurrence almost certainly is one of the major causes of cardiac cellular death during myocardial ischemia. So, ischemic heart disease. Ischemic heart disease. Atherosclerosis as a cause of ischemic heart disease. A frequent cause of diminished coronary blood flow is atherosclerosis in people who have a genetic predisposition to atherosclerosis, who are overweight or obese and have a sedentary lifestyle, and who have high blood pressure and damage to the endothelial cells of the coronary blood vessels. Large quantities of cholesterol gradually becomes deposited beneath the endothelium in the many points in arteries throughout the body. Frequently, these areas of deposit are invaded by fibrous tissue and subsequently become calcified. This net result is the development of atherosclerotic plaques that actually protrude into the vessel lumens and either block or partially block blood flow. A common site for development of atherosclerosis plaque is the first few centimeters of major coronary arteries. Acute coronary occlusion. Acute occlusion of a coronary artery most frequently occurs in a person who already has underlying atherosclerotic coronary disease, heart disease, but almost never in a person with normal coronary circulation. Life-saving value of collateral circulation in the heart. The degree of damage to the heart muscle caused either by slowly developing atherosclerotic constriction of the coronary arteries or by sudden coronary occlusion is determined to a great extent by the degree of collateral circulation that has already developed from that can open within minutes before the occlusion. In a normal heart, almost no large communications exist among the larger coronary arteries. However, many anastomosis do exist among the smaller arteries sized 20 to 250 mm in diameter. So when a sudden occlusion occurs in one of the larger coronary arteries, the small anastomosis begin to dilate within seconds. However, the blood flow through these minute collaterals is usually less than one half that needed to keep alive most of the cardiac muscle that they now supply. The diameter of the collateral vessels do not enlarge much more for the next 8 to 24 hours, but then collateral flow begins to increase, doubling by the second or third day and then often reaching normal or almost normal coronary flow within about 1 month. Because of the developing collateral channels, many patients recover almost completely from various degree of coronary occlusion that the area of muscle involved is not too great. Because of this developing collateral channels. Then myocardial infarction. Immediately after an acute coronary occlusion, blood flow ceases in the coronary vessel beyond the occlusion except for small amounts of collateral flow from surrounding vessels. The area of muscle that has either zero flow or little flow, that is, cannot sustain cardiac muscle function, is said to be infarcted. The overall process is myocardial infarction. Infarcted muscle. Myocardial infarction. Soon after the onset of the infarction, small amounts of collateral blood begins to seep into the infarcted area, which combined with the progressive dilation of local blood vessels causes an area to become overfilled with stagnant blood. Simultaneously, the muscle fibers use the large exchanges of oxygen in the blood, causing the hemoglobin to become totally deoxygenated. Therefore, the infarcted area takes on a bluish brown color and the blood vessels of the area appear to be engorged despite lack of blood flow. Within a few hours of almost no blood supply, the cardiac muscle cells die. Cardiac muscle require about 1.3 ml of blood per 100 gram of muscle tissue per minute just to remain alive. In comparison, about 8 ml of oxygen per 100 gram is delivered to the normal resting left ventricle each minute. Therefore, if there is an even 15 to 30% of normal resting coronary blood flow, the muscle will not die. In the central portion of the large infarct, however, there is no collateral blood flow, the muscle does die. Central portion of the large infarct. Then subendocardial infarction. The subendocardial muscle frequently becomes infarcted even when there is no evidence for infarction in the outer surface portions of the heart. The reason for this is that the subendocardial muscle has a higher oxygen consumption and extra difficulty obtaining adequate blood flow because the blood vessels in the subendocardium are intensely compressed by systolic contraction of the heart. Therefore, any condition that compromises blood flow to any area of the heart usually causes damage first in the subendocardial regions. Which regions? Subendocardial regions. And the damage then spreads outward towards the endocardium. Then causes of death after acute coronary occlusion. The most common causes of death after acute myocardial infarction are decreased cardiac output, damming of blood in the pulmonary blood vessels and then death resulting from pulmonary edema, then fibrillation of the heart, and occasionally rupture of the heart. And stages of recovery from acute myocardial infarction. The side effects are there. So, effects of acute coronary occlusion in a patient with a small area of muscle ischemia to right shown a heart with a large area of ischemia. Then, when the area of ischemia is small, little or no death of the muscle cells may occur, but part of the muscle often does become temporarily non-functional because of inadequate nutrition to support muscle contraction. When the area of ischemia is large, some of the muscle fibers in the center of the area die rapidly within 1 to 3 hours when there is a total cessation of coronary blood supply. Immediately around the dead area is a non-functional area with failure of contraction and usually failure of impulse conduction. Then extending circumferentially around the non-functional area is an area that is still contracting but only weakly because of its mild ischemia. So replacement of dead muscle by scar tissue. In the lower part, the various stages of recovery after a large myocardial infarction will be happening. So shortly after the occlusion, the muscle fibers in the center of the ischemia area die. Then during the ensuing days, this area of the dead fiber become bigger because many of the marginal fibers finally succumb to the prolonged ischemia. At the same time, because of enlargement of collateral arterial channel supplying the outer rim of the infarcted area, much of the non-functional muscle recovers. After a few days to 3 weeks, most of the non-functional muscle become functional again or dies, and or the other. The meantime, fibrous tissues begin developing among the dead fibers because ischemia can stimulate growth of fibroblasts and promote. That's a new point. Ischemia can stimulate growth of fibroblasts and promote development of greater than normal quantities of fibrous tissue. Greater than normal quantities of fibrous tissue. Therefore, the dead muscle tissues is gradually replaced by fibrous tissue. Then, because of a general property of fibrous tissue to undergo progressive contraction and dissolution, the fibrous scar may grow smaller over a period of several months to a year. Finally, the normal areas of heart gradually hypertrophy to compensate at least partially for the lost dead cardiac musculature. By this means, the heart recovers either partially or almost completely within a few months. Value of rest in treating myocardial infarction. The degree of cardiac cellular death is determined by the degree of ischemia and the workload on the heart muscle. When a workload is greatly increased, such as during exercise, a severe emotional strain, or as a result of fatigue, the heart needs increased oxygen. Heart needs increased oxygen and other nutrients for sustaining its life. Furthermore, anastomotic blood vessels that supply blood to ischemic areas of the heart must also still supply the areas of the heart that they normally supply. When the heart becomes extensively active, the vessels of the normal musculature become greatly dilated. This dilation allows most of the blood flowing into the coronary vessels to flow through the normal muscle tissues, thus leaving little blood flow through the small anastomotic channels into the ischemia area. As a result of ischemia condition worsens. This condition is called coronary steal syndrome. Consequently, one of the most important factors in the treatment of a patient with myocardial infarction is observance of absolute body rest during the recovery process. Then function of the heart after recovery from myocardial infarction. Occasionally, a heart that has recovered from a large myocardial infarction returns almost to full functional capability, but more frequently, its pumping capability is permanently decreased below that a healthy heart. This does not mean that the person is necessarily cardiac invalid or that the resting cardiac output is depressed below normal, because the normal heart is capable of pumping 300 to 400 more blood per minute than the body required during rest. That is, a normal person has a cardiac reverse of 300 to 400. Even when the cardiac reserve is reduced to as little as 100%, the person can still perform most normal daily activities, but not strenuous exercise that could overload the heart. Pain in coronary heart disease. Normally, a person cannot feel his or her heart, but ischemic cardiac muscle often does cause pain sensation that is sometimes severe. Exactly what causes this pain is not known, but it is believed that ischemia causes the muscle to release acidic substances such as lactic acid Lactic acid is released, or other pain promoting products such as histamine, kyanins, cellular proteolytic enzymes that are not removed rapidly through enough by the slowly moving coronary blood flow. Lactic acid, histamine, kyanin, cellular proteolytic enzymes. Lactic acid, histamine, kyanins, and other cellular proteolytic enzymes. The high concentration of these abnormal products then stimulate pain nerve endings in the cardiac muscle, sending pain impulses through sensory afferent nerve fibers into the central nervous system. Then angina pectoris, or cardiac pain. In most people who sustain progressive restriction in their coronary arteries, cardiac pain called angina pectoris begin to appear whenever the load on the heart becomes too great in relation to the available coronary blood flow. This pain is usually felt beneath the upper sternum over the heart, and in the addition, it is often referred to distant surface areas of the body, most commonly in the left arm and left shoulder. Left arm and left shoulder, but also frequently into the neck and even to the side of the face. The reason for this distribution of pain is that during embryonic life, the heart originates in the neck, as do the arms. Therefore, both the heart and the tissue surface areas of the body receive pain nerve fibers from the same spinal cord segments. Most people who have chronic angina pectoris feel pain when they exercise or when they experience emotions that increase metabolism of the heart, or temporarily constrict the coronary vessels because a sympathetic vasoconstrictor nerve signal. Anginal pain is also exacerbated by cold temperature or by having a full stomach. Cold temperature, full stomach, emotions, and exercise, both of which increase the workload of the heart. The pain usually lasts for only a few minutes. However, some patients have been severe and lasting ischemia that the pain is present in all the time. The pain is frequently distributed as hot, pressing, and constricting, and are of such quality that it usually makes the patient stop all unnecessary body activity. Then treatment with the drugs. Several vasodilator drugs, when administered during an acute anginal attack, can often provide immediate relief from the pain. Commonly used short-acting vasodilators are nitroglycerin or the nitrate drugs. Nitroglycerin or nitrate drugs. Nitroglycerin or either other nitrate drugs. Other vasodilators such as angiotensin converting enzyme inhibitors, angiotensin receptor blockers, calcium channel blockers, and ranolazine may be beneficial in treating chronic stable angina pectoris. And another class of drugs used for prolonged treatment of angina pectoris is a beta blocker such as propranolol. These drugs block sympathetic beta adrenergic receptors, which prevent sympathetic enhancement of heart rate and cardiac metabolism during exercise or emotional episodes. Therefore, therapy with a beta blocker decreases the need for the heart for extra metabolic oxygen during stressful conditions. Therapy with a beta blocker decreases the need of the heart for extra metabolic oxygen during stressful conditions. For obvious reasons, this therapy can also reduce the number of angina attacks as well as their severity. Then surgical treatment to coronary artery disease, aortic coronary bypass surgery. In many patients with coronary ischemia, the constricted areas of the coronary arteries are located at only a few discrete points blocked by atherosclerotic disease, and the coronary vessels elsewhere are normal or almost normal. In the 1960s, a surgical procedure called aortic coronary bypass was developed. Aortic coronary bypass was developed, in which a section of subcutaneous vein from an arm or leg was removed and then grafted from the root of the aorta to the side of the peripheral coronary artery beyond the atherosclerotic blockage point. Then coronary angioplasty. Since in 1980s, a procedure has been used to open partially blocked coronary vessels before they become totally occluded. A process called coronary artery angioplasty is as follows. A small balloon-tipped catheter about 1 mm in diameter is passed under radiographic guidance. Radiographic guidance is a must. Radiographic guidance into the coronary system and pushed through the partially occluded artery until the balloon portion of the catheter straddles the partially occluded point. The balloon is then inflated with high pressure, which markedly stretches the diseased artery. After this procedure is performed, the blood flow through the vessel often increases 3-fold to 10-fold, and more than 75% of the patients who undergo this procedure are relieved of the coronary ischemic symptoms for at least several years, although many patients still eventually require coronary bypass surgery. Small stainless steel mesh tubes called stents are sometimes placed inside the coronary artery dilated by angioplasty to hold the artery open, thus preventing its restenosis. Within a few weeks after the stent is placed in the coronary artery, the endothelium usually grows over the metal surface of the stent, allowing blood to flow smoothly through the stent. However, reclosure of the blocked coronary artery occurs in about 25 to 40% of patients treated with angioplasty, often within 6 months of the initial procedure. Restenosis is usually due to excessive formation of scar tissue that develops underneath the healthy new endothelium that has grown over the stent. Stents are slowly releasing drug-eluting stents. Drug-eluting stents may help prevent the excessive growth of scar tissue. Newer procedures for opening atherosclerotic coronary arteries are constantly in experimental development. One of these procedures employs a laser beam from the tip of the coronary artery catheter aimed at the atherosclerotic lesion. The laser literally dissolves the lesion without substantially damaging the rest of the arterial wall.